Good evening, everyone. Today's topic on collaborative learning activity is short answer questions on impaction, guided by Dr. Bhushan sir and Dr. Narayan sir. The SAQs which will be covered are classification of impacted canines, lingual split technique, lateral refinition technique, differences between chisel mallet and burr technique. Classification of impacted canines. The first classification is based on position in the dental arch. In class 1, we have impacted cuspids in palate, horizontal, vertical, and semi-vertical is there. In class 2, we have impacted cuspids on buccal surface, in which we have horizontal, vertical, and semi-vertical again. In class 3, we have impacted cuspids located both in palatal and labial. Class 4, we have impacted cuspids located in the alveolar process, usually vertically between the incisor and bicuspid or premolar. In class 5, we have impacted cuspid located in edentulous maxilla. So as you can see in the first diagram, class 1, impacted cuspids located in the palate. This is a horizontal impaction. This is a vertical impaction. And this is a semi-vertical impaction. In class 2, we have impacted cuspid located in the labial or buccal surface. This is the horizontal impaction, vertical impaction, and semi-vertical impaction. Class 3, we have impacted canines located in both the palatal process and labial or buccal maxillary bone. Example, the crown is on the palate and the root passes through between the roots of the adjacent teeth in the alveolar process. So here, the crown is towards the palate and the root is between the bifurcation of the roots of the adjacent teeth, ending in a sharp angle on the labial or buccal surface of the maxilla. Class 4 is impacted canines located in the alveolar process, usually vertically between the incisor and first bicuspid or premolar. Class 5 is impaction in edentulous maxilla. Next, we come to Field and Ackerman classification given in 1935. In that, we have maxillary canines and mandibular canines. In maxillary canines, we have labial position, palatal position, intermediate position, and unusual position. In labial position, we have crown in intimate relationship with incisors, crown well above the apices of incisors. In palatal position, we have crown near the surface in close relationship to roots of incisors and crown deeply embedded in close relationship to apices of incisors. In intermediate position, we have crown between lateral incisors and first premolar roots and crown above these teeth with crown labially placed and root palatally placed or vice versa. Unusual position we have in nasal or antral wall and in infraorbital region. For mandibular canines, we have two labial positions and unusual position. In labial positions, we have vertical, oblique, and horizontal. In unusual positions, we have at inferior border, in mental protuberance, and migrated to the opposite side along with the original nerve supply. Next, we come to a lingual split technique or Kelsey-Fry technique. This technique was introduced by Sir William Kelsey-Fry. This method takes advantage of the thinness of the lingual cortical plate. An advantage of this technique is it preserves the buccal plate and external oblique ridge. This technique is used for extraction of lingually impacted third molars. Let's come to the procedure now. Vertical stop cut is made by placing the chisel with the bevel facing posteriorly distal to second molar. As you can see here, a vertical stop cut is given. With the chisel bevel downward, a horizontal cut is made backward from the lower end of the vertical limiting stop cut. A horizontal cut is made here. The buccal bone plate is removed above the horizontal cut. So the buccal bone above the cut is removed. The distal lingual bone is fractured inward by placing the cutting edge of the chisel bevel side of the chisel is facing upward and cutting edge is parallel to the external oblique ridge. So here, the distolingual bone is fractured. A sharp straight elevator is used to elevate the tooth. As the tooth moves upwards and backwards, the lingual plate gets fractured and facilitates the delivery of the tooth. So here, an elevator is used and the tooth is upward and backward. After the tooth is removed, the lingual plate is grasped with the hemostat and freed from the soft tissue and removed. Here we can see this another diagram of it. The steps are vertical stop cut, horizontal cut, removal of buccal bone, fracturing distolingual bone, removing bony wedge, elevation of tooth, repositioning of flap, and suturing is done. Now let's come to the advantages and complications of lingual split technique. In advantages, we have a quick technique, reduces the size of residual blood clot by means of saucerization of the socket, decrease risk of damage to periodontium to second molar. Since it is a chisel mallet technique, the post-operation edema is lesser and healing is better. In complications, we have swelling, trismus, and bleeding. But this only occurs when the things go wrong during the procedure. Then we have neurological. In that, we have lingual nerve damage, paresthesia of tongue, inferior alveolar nerve damage, paresthesia lower lip. Then we have extensive fracture or bad fracture of lingual plate. Though this procedure requires bone removal, but not extensive. So here again, if things go wrong, there might be a bad fracture. Loss of tooth into submandibular and sublingual space, mandibular fracture, and in second molar, we have hypersensitivity, disturbed periodontal pocket, and gingival recession. Next, coming to lateral refinition technique. This was first described by Baudelaire and Henry to remove any partially formed and unerupted third molar. It has been employed to remove such teeth from patients from 9 to 18 years of age. So basically, this procedure is a prophylactic measure of removal of third molars. The bone healing is excellent without any loss of alveolar bone around the second molar. So let's come to the procedure. And a modified S-shaped incision is made from retromolar fossa across the external oblique ridge to the distal side of the first molar. As we can see here, an S-shaped incision is given. The full thickness mucoperiosteal flap is elevated and refracted using a Baudelaire-Henry retractor. Buccal cortical plate is trephined over the third molar crypt. This means that perforations or holes are made on the buccal cortical plate. Burr is used to make vertical cuts anteriorly and posteriorly on the external plate. As you can see here, anterior and posterior cuts are made. The buccal plate is fractured using a chisel. So using a chisel and the perforations and the cuts, the buccal plate is fractured. Using an elevator, the impacted tooth is delivered out of the crypt, and then it is sutured. Now let's come to the indications. So why do we use this technique? As I have mentioned earlier, this is a prophylactic measure for removal of third molar. So coming to indications, partially formed unerupted third molar can be removed, prevention of crowding of mandibular anterior teeth, prevention of odontogenic cysts and tumors, orthodontic considerations, prevention of caries, prevention of root resorption of teeth, prevention of periodontal diseases and pericoronitis. Now coming to our last SAQ, differences between chisel mallet and burr technique. Chisel mallet technique, as you can see, a chisel and a mallet is used. A chisel, as you can see, is a monobevel instrument used for removal of bone. It has a heavy metal or a fiber handle. For cutting or removal of the bone, the bevel is placed facing away from the bone or the bevel towards the bone to be removed. This is a mallet. The mallet is made of wood, rubber, nylon, or stainless steel. The mallet is designed to weigh 8 ounces for delivering controlled force on the chisel or osteotome. Burrs, as you can see, are stainless steel or tungsten carbide rotary cutting instruments used extensively in hard tissue surgeries. So coming to the differences in criteria, we have chances of bone fracture. It is relatively high in chisel mallet technique and a less possibility in burr technique. Healing of bone is good in chisel mallet technique and delayed in burr technique. The post-op edema is lesser in chisel mallet technique and more in burr technique. Dry socket incidence is less and higher in burr technique. Post-op infection is less in chisel mallet and more in burr technique. Deeply buried tooth, difficult to remove in chisel mallet technique and relatively easy in burr technique. Thank you.